Kia ora everyone and welcome to our Goodfellow webinar on sexual dysfunction in men when Viagra doesn't work. My name is Dr. Grace Lee. I'm a GP and I also work for the Goodfellow Unit. Tonight I have the pleasure of talking to Dr. Warrick White. Warrick has a background in general practice, but he's also had over 25 years of experience treating men with sexual difficulties in his Auckland Men's Clinic in Epsom. Over to you, Warrick.
Good evening. I've been asked to talk on a very common topic that you'll see in your practice, what to do when sildenafil does not work. Sildenafil, of course, is Viagra, Sylvester. There's a variety of company names, and it has been around for 20 years. So it's timely that we reviewed this drug. I have been a paid advisor for these companies. I'm not at the moment, but I'm supposed to disclose that. And so what we were going to talk about tonight was just to talk about ED a bit, because there's some confusion. You want to know if the diagnosis is correct, and what do patients mean when they say sildenafil, Viagra, Sylvester, or whatever is not working. You want to know whether it's being used correctly, and given the underlying cause of the ED, which we'll talk about, maybe other therapy is more appropriate, such as injection treatment or psychotherapy. 1998, Viagra came on the market and it was going to fix everything. It hasn't really worked out like that. There's a short slide here that you don't have to understand, but basically Viagra works. It's a PDE5 inhibitor, and it works by, I say to the patients, because people don't want to use drugs for sexual function, and I say, well, this is just enhancing the normal sexual process. When you have sexual stimulation, is there a marker on there that I can?
Can I bring the mouse over?
Oh yeah. Okay. That. So there's it was sexual stimulation, GTP, cyclic GMP, and it goes through this process and it causes smooth muscle relaxation. And PDE5, which should have a little line through it there. Yeah, stops that. And so basically it's enhancing the vasodilating process that you're required to have to make erection work. And so I tell patients that this is just making the natural process better. And it does actually work, but it does need sexual stimulation to kick it off. It just doesn't have you walking around with an erection, although that a lot of tacky sitcoms would have you believe. The definition, because people talk about ED all the time. I've got ED, I've got erectile dysfunction. My wife told me to come and see you because I've got ED. Well, what does that mean? That's a persistent inability to achieve or maintain an erection sufficient for satisfactory sexual activity. And you just have to know that that's, so what you're talking about is what you're trying to treat. And over the years, it's become obvious that ED means more than just about sexual function. It's related to endothelial dysfunction, emotional dysfunction, and there's embarrassment and distance, so that people don't really communicate about this very well. The treatment for someone with ED is if you've established they've got that, is a trial of drugs, sildenafil or tadalafil, which is Cialis. They both work well. The only real difference is tadalafil lasts for longer and the side effect profile is a little bit different. The main side effects that people complain of is headache, and that can be for both of them. Tadalafil, the real side effect that can worry some people is bone aches and pain, and that can last for a couple of days, and it can be real like a flu-like illness, and that'll certainly put you off using it. But most people can take these drugs without difficulty. It's dose related, so that when people think, oh, one sildenafil isn't working, maybe I'll take two. Well, that's not unsafe, but it probably doesn't make a whole lot better function. If it's not going to work on one, it probably is not going to work with two, but the side effect profile will dramatically increase. During the early days, we had no shortage of volunteers taking sildenafil, and we had people taking up to 8 tablets at a time, and there were no really bad or dangerous side effects, a lot of bad headaches, but it didn't make the erection much better. It just made a lot more side effects. If that's not working, you can use self-injection, which we'll talk about a bit later. And there's vacuum devices that have been around for years and implants that have been used widely in America. We do have a few patients that have had these done in, they do them at Ascot with Don Tuckey, who's got a particular interest in this problem. Of course, always psychology is a good thing, counselling is a good thing, that can be helpful. And it doesn't matter what the cause of your sexual dysfunction, it can be very disturbing, and psychologists can often help in this regard. So you've established what is the problem, erectile dysfunction. People come in with issues and they say, I've got an ED, but they might mean they've got premature ejaculation. Sometimes they just mean I'm not interested anymore. Sometimes they have numbness or loss of sensation in the genital area. Certainly, we see people with delayed or absent orgasm, especially in men as they get older, or in diabetics. There's a complaint about reduced ejaculate, which will happen, and which is really, as time goes on in your life, the volume of ejaculate will decrease, the urgency to ejaculate will decrease, the ability to ejaculate more often than once in a 24-hour period or a long, it will be complained about. Painful intercourse can be an issue, and of course there's always relationship problems, which we'll talk about a bit later on. So guess what you do? Like in all parts of medicine, you take a history, because people say, I don't know what to say with these guys. What am I supposed to do? Well, you do what you do with someone coming in with chest pain. You ask them, what's going on? Ask them to say, what do they mean? What is their real problem? And say, what happens? And they will be thrilled if you make them comfortable and ask them these questions. You don't just gloss over it, because they've often been waiting, certainly men wait 3-4 years before they will come and present with this. So you do not want to just discount their complaint as something trivial. And you ask them, are they able to have intercourse at all? Does it work for them? Can you maintain erection? Sure, you might get one, but it might just be lost very quickly. An important question is, if you're by yourself, can you get an erection? And people will look at you awkwardly and say, oh, I'm not supposed to do that. But it's a very good question, because sometimes it will work very, very well early in the morning. It'll work in the middle of the night. It'll work by themselves. It doesn't work with a partner, and that's worth talking about, because sometimes the relationship is more of an issue. Then you must ask, is that ejaculation is it too quick? Some people, it's too long. And you have to ask, what does that really mean? Because I have a sort of mental note of these things, who's got the record holder. At the moment, I had a man referred to me by another doctor, referred for premature ejaculation. No one had asked him, how long did this go? His wife had said, you know, you're not very good. I think you've got premature ejaculation. He could last 45 minutes. So you've got to, don't take people at their word when they say it's too quick. And then people saying it's too long, look, it just goes on and on and on forever. We'll say, okay, tell me, does that mean 2 minutes, 5 minutes, 10 minutes? And you'd be surprised how many people will be complaining that they can never come to climax, and intercourse is lasting 3 or 4 minutes. And you're thinking, really, too quick or too long? And too quick or too slow. Oh, I thought I'd repeated myself. Yeah, too quick or too slow. And I think you just have to ask people about that. I mean, and if this is painful, I did have a man who came to me because of ED, and he had painful intercourse. And I said, well, we'll examine you. And I don't think there's any need for that. A lot of people will say, because they're embarrassed. And I say, no, look, it's a good thing. Just have a look and see. And I think people realize that you're taking them seriously. And this young man was about 26, 27, and every time he tried to have sex, it was too painful. He'd had a few girlfriends, and he said, I don't understand what's going on. No one had ever looked at him. So he didn't have any problems. When you looked, he had normal scrotum and testicles and a very adequate penis. And I said, well, can you pull your foreskin back? And he said, I'm circumcised. And I said, oh, yeah. No, you're not. And I said, you're uncircumcised. And every time you have an erection, he was trying to split his foreskin. Of course it was painful. No one had ever looked. He went and had a circumcision, and bing, he's completely cured and very, very happy, realizing that he had a real problem. I had another man who was sent to me through lack of interest, just on the examination story, he had a lack of interest in sex. He'd been reduced desire and inability to have sex. And I said, well, okay, let's have a look at you. And he said, again, oh, well, I don't see, how's that going to help? Well, I said, oh, I'll just have a look. And I said, well, since when didn't you have any testicles? He said, oh, they were taken by a doctor because I've got prostate cancer. Really? And he'd forgotten? And he'd gone to a different doctor and found his way to me. No one had looked at him. I think that's pretty significant. And it's all about have a look. And if you don't they say, if you don't look, you don't know. And it is helpful. So it may not be erectile dysfunction. It could be one of those annoying pop-up ads. Yeah. So I think, although we're talking about what happens when Viagra doesn't work, this is really very closely related to premature ejaculation. And so what does that mean? People say, oh, I've got PE. Well, what? They last 3 minutes, 5 minutes? They haven't got PE. That's actually within normal range. So it's got to be the proper definition. They have to have all three of these things. Ejaculatory. So actual intercourse is less than a minute. Doesn't matter what they do. They've got no control over this, and it's negatively impacting the relationship. Everyone's stressed out. They just can't do anything about it. That is premature ejaculation. And you want to have a bit of an idea of what's normal, because people just don't have any idea. And look at along the bottom of this, look at the dates on this data. 2005, 2008, Chris McMahon, who's the Australian guru on all of this stuff, they did this stuff. This is very recent, really. We did not know what was normal. Most doctors know what's normal because they know their own range of normal. And they think, oh, I'm pretty normal, so my normal is everyone's normal. Well, sorry, it doesn't work like that. Like everything else, we've got to look at the data, and you've got to see what is reasonable for a large crowd of people. And basically, they're the people in trouble. And right at the very bottom, down here, these people often are pre-portal ejaculators, and so there are a few unlucky fellows at a suggestion of sexual interaction, they will ejaculate. So when you say, would you like to come home to my place for coffee? And they'll say, oh, that's a good, sorry, too late. And sadly, that's what happens. But that's very rare. But these people, can be helped with medication. But sometimes they just don't get to, get to first base. And mostly these people just give up because it's just too desperate. And these people in this group, their partners get frustrated and nobody knows what to do. And they'll say, oh, can't you last longer? Well, no, you can't. Look, a lot of men have premature ejaculation at some time, and that can just be related to the situation, the partner, or whatever. But really 1 or 3% would have really true PE, and these guys can be desperate. Interestingly, I saw a young fellow with PE, and then his brother came to see me. And then a third guy came to see me, and he was his third brother. And then after that, their father came to see me, and all of these guys had PE. And the father didn't know anything could be done about it. And because he had been married and they had a happy life and he had 3 boys, he figured he was normal. But he was terribly distressed by this PE. His wife had given up on sex because it was very unsatisfying. The Guardian last week, or the week before now, published some data, so I suppose it's reliable. It's in the Guardian. Average time for women to climax was 16 minutes. Average time for men, 3 to 7. So it's a bit discordant, isn't it? And I think you need to be aware of that. And you ask men, does your wife or your partner have orgasms? And so often men will say, and these are people who have been married for 20, 30 years, they'll say, oh, Doc, I'll ask her and I'll tell you next time. And I think we know the answer, don't we? So the treatment for premature ejaculation, look, counselling, it's never really going to work without some other help. The stop-start technique, these things have been around for years, and basically they're pretty self-explanatory. I think you've got to have more sex, and I say to people when sex isn't successful, they're likely to say, look, I don't do it anymore because it's just so dissatisfying and unsatisfying, and I've just sort of given up. but I try now and again. And I equate that to the tennis game. You know, if your tennis isn't very good, you don't just put your racket in the corner and think, I'll have another game next month and see what happens, because you're not going to get any better. You have to practice. And if you don't have frequent sex, you get a build-up of pressure. You're going to be more likely to ejaculate faster. And you have to keep doing it. Sex is practiced and learned behaviour, and you have to keep doing it.
Just a quick question. Is there any role for using agents such as lidocaine to reduce the sensation for premature ejaculation? Oh, here we go.
Perfectly timed question from our host. Yes, local anaesthetic agents. You can buy sprays from sex shops, and there's a local like Stud 100 and things. They're locally anaesthetic sprays. I've used EMLA off-label for years, and you can actually now get EMLA-coated condoms, and you can put EMLA. If you leave EMLA on for a long time, you can't feel anything. And I usually tell guys to put it on, leave a condom over it for 15 minutes, 10, 15 minutes, and it'll just reduce some of the sensation. You want to make sure you wash it off if you don't use a condom. And one young guy in his 20s who came to see me, and he was desperate with PE, and he'd never been able to last more than 30 seconds. He started to use EMLA, and he came back to see me and was totally thrilled. He was lasting 30 minutes. Good. So it was clearly a hypersensitivity of the glands. Some people, that is just how they are, and it really helps. And you know, this isn't psychological, because when they stop using the agents, they go back to where they were.
Does the EMLA have any issues with integrity with the condom in terms of?
Well, they sell it as a EMLA-coated condom, right. So I think it works. Yeah. I think, yeah, sensibly good point is if there's in some sort of carrier that the EMLA is in, is that going to affect that? To be perfectly safe, you'd wash it off. And then, you know, if you were really worried about the condom falling apart, we'd look a bit silly if that happened, I suppose, wouldn't we? And of course, SSRIs, off-label use of the SSRIs, and the best one is paroxetine. And sorry, there was dupoxetine, but I don't think you'll find that available anymore. I looked just before I came tonight at a pharmacy, you know, online, and they don't have it. And I've had a few patients coming and asking if they can get it. It was just old-fashioned SSRI that was being marketed, and it was expensive because you got 3 tablets for about $75
wow.
or something.
Okay.
And you'd have to use a tablet every time you wanted to have sex, and you know, so you can get paroxetine for $5, you can get 90 tablets, and it's still a reasonable use, you know, if you're going to obey the law and prescribe according to indication. It's still an anxiety thing, and then tablet's an anti-anxiety tablet, and it's a great tablet for panic attacks and calming people down. So it does work, and I think you really, to get the best effect, you should take you usually start with half a tablet a day for 2 weeks, and if it's not working, then you would go up to a full tablet a day, and you really need to stay on it. Now, I do have the occasional person take us on a PRN basis, but that's not actually guaranteed to work. But I have a few guys that say it does actually make a difference. But it's absolutely changed the treatment for this condition, which is terribly frustrating for people who don't understand it. They can't see why can't you just stop. You just can't do it. This isn't in your mind. This is real. And so much of sexual medicine is real. The people who say it's all in your mind
before we move on, sorry, we've just got one more question before we move on with regards to slides. Someone's just wondering, with regards to the EMLA application, do you apply it just on the frenulum or do you apply it all over?
No. I put it, just on the gland. You know, we can put it everywhere, but mostly just on the tip is where all the nerve endings are. So you just put it on the glands.
Thank you.
And you've got to put on a reasonable amount, you know, for it to work, don't you? Yeah.
Okay.
And of course, we say you can't treat premature ejaculation with Viagra because so often guys will turn up to me who've been given Viagra. Well, it's the wrong thing, with one exception. which is the vicious cycle. So you've got a bit of erectile dysfunction, your erection isn't so good, and so you're here, you go up to stimulation to regain the erection, you have premature ejaculation, and so then you go back down here and you lose the erection, and you go around like this. So if you take Viagra, you mean you've got a much stronger erection, and then you don't have to rush, and therefore you're not overstimulating things, and you're likely to regain control. So these guys present as premature ejaculation, but if you take a good history, they haven't actually got premature ejaculation. They've got erectile dysfunction or just weakening erections, but they're in that vicious cycle, and they will get better if you give them Viagra. So we've asked the patient all this, and we know that his problem is erectile dysfunction. So you're probably aware of the causes of it, but the most common cause you're going to see in your practice is increasing age. And I think you want to make it easy for people when they've got problems and they're coming in and they may be asking, they've got their repeat tablets for their hypertension or their diabetes, and you don't ask them, have they got any problems with sexual dysfunction? Because every bloke in the room will say, God, me, not me, mate. They will hate it afterwards when they get outside. They'll think, God, that was the opportunity. I could have said something. So you've got to say, look, mate, at 69, with all of these other things, you're a real sitter for problems with sexual function. I guess yours is pretty rubbish like everybody else's, and make it easy for them. And they'll say, oh, thank goodness, yeah. Gee, yeah, the wife's giving you a bit of curry about that, and then you can talk about it. But it's very hard sometimes to introduce this topic, and especially as you're trying to see one patient every 10 or 15 minutes, you really don't want to open Pandora's box with all these other problems. You've just got them through, and you've done their blood pressure, and you've done the other bits and pieces, and you've done the foot exam, and you're thinking, I'm running out of time here. Do I want to bring up the topic of sexual dysfunction? That's good for half an hour, because remember, this has been bottled up for 2 or 3 years, and they really want to talk about it. You've got to think about people with diabetes and spinal trauma. We have quite a few guys in wheelchairs, and treatment is just fantastic for them. Of course, prostate and bladder and bowel and all these things. These guys are having problems when they started doing robotic surgery. All my nice colleagues said, well, that's you done, Warrick, you'll be out of business because this is wonderful. Every time something new comes out, people will predict things that are not necessarily true, and what has happened, we have got busier. There are more people having their prostate operated on. These guys have trouble. Now, of course, I don't see the guys who have these surgeries and don't have issues, except the chance when I'm seeing them for something else and they happen to have had this surgery. But most of the time, people have this surgery, you need to expect that they're going to have difficulties. Lots of drugs prescribed can cause this, but really most of the time you're giving people drugs because they need them for something else, so you really can't change that. But the alcohol consumption is over and above all the most dramatic thing that we have in our society, and people's consumption of alcohol is extraordinary.
Just a question with regards to the medications. Would you be able to just give us a few examples of commonly prescribed medications that cause erectile dysfunction as a side effect?
Yeah, I think the most common thing is beta blockers, and they're dramatically bad. I think people find sometimes they're antihypertensives. You drop the blood pressure, it's dropping the pump pressure, and some guys find on Friday night, I don't want to take my tablets because I'll get a better erection. I'll catch up on Saturday, so it should be all right. I don't really know whether that's a great idea. I've got a great big book that I bought about drugs and erectile dysfunction, and just about everything seems to be possible to cause it. But really, yeah, I mean, antidepressants all have that down, don't they? But you can't take people off, and every other person seems to be on citalopram or something. And you really can't stop these drugs because they're very good drugs. They do a terrific job. But yes, as a consequence, you may have sexual dysfunction as a side effect. But yeah, I suppose looking at their drugs is interesting, but most of the time you say, well, we're probably going to have to give them some drugs, more drugs, drugs for their sexual dysfunction, because the other drugs they have to take for their diabetes, blood pressure, etc., are just causing these other issues, but we don't want to stop them. I mean, other problems you see are Peyronie's. It's quite common. scarring in the penis. And the general rule is guys who come with a bent penis and say, gosh, my penis has got a bend. It'll be, most commonly it will be dorsal bend, but it can be left or right. Less commonly, thankfully, it's ventral, it's down, because that makes it very difficult to have intercourse. And quite often the point after the scar tissue in the penis will not fill with blood, so it won't erect. So it can be quite soft, so it can be difficult. We rarely see people whose Peyronie's is so bad that they have to have surgery, but they have Nesbitt's procedure. Well, they cut out little bits on the side to sort of square it up. And I think when it gets to that, they're going to be in the hands of the urologist. Venous leak is a very interesting condition, which I'll talk about a bit later. And look, everyone wants their testosterone measured. It's rarely the issue that's causing their ED. And I think replacement of testosterone is one of the more disappointing treatments that you can embark on. People expect a large amount of success from it, and it's very disappointing. Certainly can make you more interested in and think, oh my goodness, there's a pretty girl walking down the street. Pretty boy. I don't want to be sexist. I mean, go with me here, and we're not trying to offend anyone. But the testosterone will switch you on, give you more energy, give you a bit more get up and go, but rarely is it low. I've just had a man who came to see me whose muscles had just all wasted away. He said, I think my testosterone, and it was, and I just about fell over. And his pituitary things were through the roof. I had never seen such levels, and his testosterone was sort of 1 or something. So we see a lot of people with testosterone 6, 7, 8. I mean, are these people helped by testosterone? A lot of them say they feel better, but is their sexual function improved? Really, it's very disappointing. Certainly, psychological treatments are always good, as we said earlier, especially in depression.
Before we move on, just a sort of few questions that have popped up and comments around the medications. Someone's just querying whether cannabis fits under that recreational drug that causes erectile dysfunction. And someone else is just wondering about safe levels of alcohol intake with regards to reducing the potential effects of erectile dysfunction.
Well, I think the thing is, if you've got erectile dysfunction, because you're drinking too much, stop drinking. It's probably not just going to come straight back. And the guidelines tell you 15 standard drinks a week, 2 days off, and no binge drinking. I mean, that's what pops up on the front of my med tech, and that's what we're told to ask people. And I think when you say, a glass, well, they've got to start arguing about how big the glass can be, and it should be 150 mils. And I think I say to guys, look, you can either have sex or you can have a drink. But so many of my patients, if I say, it's okay to have a drink. Like Lily said to me, because I was giving a talk for them, that you should have said it's okay to have a drink with Cialis. I said, yeah, but if I give guys permission to have a drink, they'll have 5. And then they'll be going, no, it's not working because they've anesthetized themselves. And their idea of a drink is often a very big drink, much bigger than the guidelines would be suggesting. I think cannabis is, look, all drugs often initially will improve sexual function, and people will say, hey, it's fantastic, and then it's not fantastic. And I don't think we can say that's it does vary the sexual experience for some people, but I don't think we can endorse it as a good thing. It's probably not great. I think if you're smoking cannabis, you're likely to miss the opportunity for sexual interaction because you've nodded off, or you've just been going so slowly, or had one of those extraordinary absences that people like that just stop in the middle of their sentence, and you're thinking, what's going on here? So it's not exactly a great party drug, I think. But I'm not an expert on cannabis. I don't want to get myself into trouble talking about that. And when we talk about treating with Viagra, these things are really not going to respond that well to Viagra. We're not going to expect that. I mean, if you're going to drink and take Viagra because you think I'm just going to overdo it, well, override it. It's not going to work. Venous leaks, certainly, again, we'll talk about this, is not often doesn't, and that's often how we diagnose it. It doesn't really respond to Viagra. And so, looking at a case, this is a real guy, okay, and he's 61 years old. He's had 3 years, standard sort of time before he comes around to talking to you about it. He's got a bit of high blood pressure. He did smoke a lot, but he stopped that. He drinks 4 glasses of wine a day, which is too much. He's on some tablets for blood pressure. He's avoiding intimacy. That's how us blokes deal with this. We just sort of make an excuse. I've got to do the GST tonight. Oh, I better put the rubbish bin out. Oh, look, there's something on TV. And we avoid. The partner's unhappy. She doesn't know how to bring up the issue, and it doesn't go very well. And I think what he's getting in the usual story, partial erection, which fades, so he's unable to actually achieve intercourse, certainly to ejaculation. He can sometimes do it when he's by himself because the stimulation is just more intense. And he tried 50 milligrams of sildenafil. That's what his doctor gave him. And that's because if you look at the drug sheet, it'll tell you that start with 50 milligrams and increase. And he said, well, these are the things that you can't do anything about, and that's the thing that he's got to deal with. But he tried the sildenafil and said it didn't work, and he came to me. He was really unhappy. He said, "Don't worry, that was a waste of time, mate. Didn't do anything." Well, he took 50 milligrams, and this wasn't from me. He came to see me after he got this from someone else, and he said, well, that's what they told me to take. And he took it, and I said, you took it after dinner? Yeah, we went out to dinner, and then I came home and thought, we'll try this tablet. And they watched it. And I said, what do you mean? You just sat there? Oh, the wife watched it too. So you both watched it. And they both sat there, side by side, looking at it. And I said, okay, what happened then? Did you touch it? He said, oh, can I touch it? I said, the true story, the true story. You can't make this stuff up. I said, it's your penis. You can touch it. And in fact, if you don't, it's certainly not going to work. It needs stimulation to optimize the effect. And he only tried it once. So, I mean, if you're going to use sildenafil, you need to be in a comfortable, non-confronting setting. You don't want your wife standing by you with her hands on her hips saying, well, come on, you're useless. Now you're taking a tablet and nothing's working. You've got to say, we're supposed to be doing this to have a good time. This isn't a competition. All the time, you start at 100 milligrams and you back titrate. If that works really well, great, go to half. But these guys have already had lots of failures. You don't want to just keep failing. And you take it on an empty stomach. Don't have food. Doesn't matter what they say, oh, can be taken with food. Because I just looked up the drug sheet before I came here to see, I wonder if they've changed that. And I say can be taken with or without food. Take it on an empty stomach. Wait 45 to 60 minutes to get maximum absorption. Now, it might work within 30 minutes or even shorter time than that, but give it plenty of time to work. I've got a 75-year-old patient. He says, I have to wait 3 hours. And he said, after 3 hours, it's working. It wasn't working. And he said, I realized I just wasn't giving it long enough to go through my very tired system to get going. It requires stimulation. It's like making bread. You don't put the yeast in the flour and just look at it. You need it together. You need to get the circulation going. And so that means hands-on stimulation. And you want to try a full tablet, and you want to try it at least 6 different times. This is what the trials show. Until you've actually done that, you can't say whether this works or not. You do not try it once and say it doesn't work. And it's interesting, the number of guys who come to me, and they're sort of almost like victorious. Yeah, well, that didn't work, so what are you going to do now? I mean, it's not a competition. I'm saying, I'm on your side. I'm on your side. Let's just relax and see whether it works. So you've got to give that good trial. So when people say, I've tried it, don't take them at their word. Just drill down a bit. Ask what they're actually doing. Now, it still might not work, but you've got to give it a fair go. Otherwise, it's not actually a trial. So there's another guy, he's 29 years old, young guy, financial. So he goes to the doctor, and people say, gee, Andrew, well, what's your problem? Oh, I'm having a bit of a problem with erections, actually. It's pretty difficult for a 29-year-old to go to his crusty old doctor and talk about this. And it's quite often this consultation degenerates into, Andrew, at your age? Oh, come on. What are you talking about? You don't need, you've just got to not do that. And I just see so many people who come to me and I say, I went to my doctor and he brushed me off. This guy can be suicidal with this, honestly. And he says, all my life, my mates say, oh, they just get erections, they go out with girls and everything works. It really doesn't work. And I had a couple of partners and they said, well, what's wrong with you? And he said, well, I don't know. What should be? They don't know. They don't know what they should be doing. And so they get very sad. So he's not drinking, he's not smoking, he's very fit, he doesn't take any medications, and he's tried sildenafil several times. And he's tried it properly because the doctor came to my talk. And so he went and tried it a few times and it didn't work. And I think you've got to understand about the anatomy of the penis so that the arteriole is here and there's another one on this side. And the blood rushes in here with sexual stimulation and it fills up in the corpora. All of this fills up and it's like pumping up a bicycle tube. Now this outside is really tough tissue, the lining. And so that pumps up, and out here you've got veins which are draining the blood, and these get compressed against the outside, and so the blood can't get out. And so the healthy young man will lock on an erection until the moment of ejaculation, and everyone's happy. But sometimes you have maybe it could be this vessel is just not locking off. So it's a bit like filling the sink up with a plug that's a bit too small for the hole. So it looks okay when you start, but very rapidly the fluid just leaks away. So the erection can start with a lot of stimulation and then it will fade away, and she'll say, what's wrong with you? Or he'll say, what's wrong with you? Depending on your relationship. And it's, I don't know, it's just not very strong. And Viagra often isn't strong enough to override this leakage. And so it may improve things a little bit. Certainly in a young man, it might improve it enough to work, but very rapidly this leak will go away. It will drain the blood away. And that's a venous leak. It's really hard to do a test for this. I mean, people do Doppler color flow studies. I have seen a lot of these done. I don't know that they're subtle enough to pick up these little changes that will cause this.
How common is this issue of venous leak?
It's not that common, but it's common enough that I've got a bunch of guys who have got this, and the treatment for them is injections, which will work, because the sildenafil just isn't strong enough to override this leak. And interesting, I'm involved with a trial at the moment where we've got some patients and we've got some a surgical intervention that we're trying. Now that people have already, because you'll say, well, why don't we just lock off the vein? No, if you tie the vein off or treat it like varicose vein surgery, you just open up another collateral and you get collateralization. So you tie off one, you come up here and you just think, I can see this vein, so I'm going to tie that off. Well, that's great. Well, you might get some improvement for a month or two, and then rapidly another vessel down here will open up and take over, and you tie that. So you're just chasing your tail. You never do it. But what we've got another process that we can't talk about at the moment because they make you sign all these secrecy things. But if anyone's got a patient like this, please let me know, because I'd like to put them in touch with the trial arrangers. Am I allowed to do a plug like that? Maybe not. But because this is quite exciting, because this is a real problem, and these are healthy young guys doing nothing wrong, and they just don't get it, and they can have erections with injection treatment, but not the sildenafil. It's disappointing.
Sorry, someone's just wondering, what else do you have to exclude before coming to the conclusion that venous leakage is the problem?
Well, the fact that you haven't got anything else. Well, of course, you can have these people aren't vasculopaths. These aren't hard drinking, hard smoking guys with high cholesterol and blood pressure and that. And these guys we know are going to have trouble. These guys are healthy people who are sportsmen and triathletes and mountaineers, and they're doing everything right, and they've never really had a cigarette in their life or anything. And this has been lifelong. This is not just something that's popped up. It can get worse as your life goes on, and I think that's because your erection isn't as strong as you're older. And in the early days, you can override the leak by just really trying harder and having a huge sexual drive. But I think it's a diagnosis of exclusion.
Okay.
And so, yeah, he tried, some people can get benefits, certainly younger people, but the treatment for him is intracorporeal injections. And that's the intracorporeal injections are Cavaject, which I haven't got a slide of, but that's still available in your pharmacy. I think if you're going to use Cavaject, you must absolutely do a trial in your office. And people will try and say, oh, I can just use this at home. I'm sure I can do it. You mustn't do that, because they will try, because it's embarrassing. I'm going to get an erection in some guy's office. This is pretty weird. I don't feel comfortable doing it. Well, actually, I'm amazed the number of guys, we would do this every week. We've got lots of guys every week would be doing this. And you'd just be matter of fact like you are with any other clinical examination, and people are fine. They just want to be helped. They just want this stuff to get sorted out.
So with an intracorporeal injection, how would one go about getting comfortable as a practitioner with regards to understanding the cost of it, where they access it, and what sort of education should we be giving our patients?
Well, you shouldn't just buy them. I've had people turn up with a prescription with a Cavaject, and they've been given a prescription. They've got it at the pharmacy. They've gone home and they think, oh my goodness, this is an injection. Well, you can't just do that to people. You've got to show them how to do it. Do it in the office and give them a small dose depending on their situation. If they're, hard drinking, hard smoking bloke, you're going to start with 10 micrograms perhaps of Cavaject and just use that and see what happens, and then you can increase the dose. From there, you don't want to give them a big dose, because I don't want to get sidetracked into priapisms, but you can give them a priapism. Now, this hasn't happened. We've been doing this about 25 years, and we've had probably half a dozen priapisms over that time, maybe a couple more than that. 3 of them I can recall have been conscious overdoses, because these guys have had new girlfriends. And one guy who was in the hospital last year was a gay guy who was a professional dancer in a club, and he discovered this and he thought, oh, this is a great idea. And he just overdosed himself. And this was just dealing with potent drugs and being silly. That's why these drugs are on prescription, because you've got to be sort of sensible about it, because you can completely wreck your penis. So you would try a small dose in your office, but you probably have to come along to me with your patient and we would talk through it. I learned this I was working in a Sydney centre for men for a while, where I went to learn about all of this stuff, where they've got a very, very big practice before Viagra. So the only treatment was injection. So everybody got injections. So we got a lot of practice at doing it, because you'd see 10, 15 patients a day that you would be injecting. So you get the idea. So once you can do it, it's actually a really easy thing to do. It is not painful. And I think you want to say that to your patient. This is a real option. Now, I was called by a colleague of mine, and he might be listening tonight, so he'll recognise this. But he said, I've got a new patient. I've got a patient who's got a new problem. He's just had his prostate out, and the physio said he needs to do some exercises to get things going. Well, how important is this? And I said, well, I think it's really important. And I think from an early stage, you should be using intracorporeal injections. And he said, what? Into your penis? Jesus, I wouldn't do that. You're not going to do that, mate, are you? You're not going to do injections. Oh, really? Oh, that's not, what a terrible thing. And I see this all the time. Patients come to me and say, oh, my doc says you're the bloke who shows you how to do injections. He says he'd never do it, but it's my choice. I've got to do so much damage control. Tell your patients this is easy. This really works. It is not like sticking a needle in your leg. And I see guys I saw a guy with full body tattoos from a Samoan bloke. He said, oh, I don't want to do needles. I'm going, come on, you've got full body tattoo. And he said, oh, that was traditional, that's different. I'm going, okay, I don't want to get caught up in cultural things here, but it would seem like that would be a lot more painful than a 29, 30, 31 gauge needle. These things are almost like a hair. They're so thin. The needle on the new Cavaject now is so thin. you're not even going to feel it going in. Really, it is that thin.
Any issues with scarring?
A lot of I've had a lot of people say I'm worried about this. I've never really seen it. I've never really seen. Theoretically, yes, you would see it. Now, when you've got your diabetic doing 5 injections a day and they've got to move around on their abdomen because you can get issues with that. These guys are doing it once a week, once every 2 weeks. Everyone, when they haven't had an erection for a year, they go, oh my goodness, this is fabulous. How often can I use it? Can I use it every day? Can I use it morning and night? And I said, look, the general, I suppose it's an urban myth. People have always said, look, you can use it 3 times a week or every other day. I don't know if there's any science in that, but I say to people, just use it whenever you want to, because they're going to use it 3 times in the first 3 days, and then they're going to say, oh, well, that was great, but they might use it next week, and they'll slow down to once a week or once every 2 weeks or once every month, and it's just nice to know that it's there. So I don't think that's a problem, and I really don't think scarring is any issue. And I have said to quite a few guys, look, what if you did get scar tissue and your penis didn't work? And they say, well, it doesn't work now, so I'm not that fussed. I'll just want to get some more mileage out of it. Because when we started this, we didn't know, were we going to be able to inject for 6 months or 2 years, or would it keep working over that time? Well, I've got guys who've been injecting 10, 15 years perfectly happily and having no issues at all. They might get the odd bruise or something when they're a little careless, or they've had a couple of drinks and they don't do it right. But really, it's very, very well tolerated.
And the average cost of one of these?
I think an injection, you'd be looking somewhere between $20 and $35.
Okay.
So it's not nothing, but either is a beer down at the viaduct. And I think I don't think you should judge people when they come to you looking a little bit down at heel and thinking, well, I won't talk to him about this because it's expensive. You'd be surprised to people that will come to me and I'll say, well, we could get you, this is stuff, we tried it, it's working really well. I said, well, it might cost you $400 for a course of treatment. They say, where can I get it? Because they're very keen. People buy big colour TV sets and mags on their car and they don't have 2 cents to rub together, it seems. People do have money for stuff that's important to them. And people, this is important. And I said to one guy, I'm sorry, this is going to cost you a few dollars. He said, look, a divorce is going to cost me $500,000. This is cheap. And truly, it is a life-saving sort of thing.
This this has stirred a little bit of questions on our question board. So just before we move on, someone's wondering, is the sensation preserved with the Caverjet, and is the ejaculation the same?
Yes.
Yes. Okay.
Yeah, no, it doesn't interfere. It might in fact enhance the sensation because you've just got a harder erection. With a harder erection, it just feels better, more positive feedback. One side effect of Caverjet, there's a small number of guys who can get prostaglandin pain, and so it can hurt. Now, I have had the odd guy, I've given a demonstration injection, and it's been really painful. I have to follow it up, and you can just do intracorporal xylocaine, just plain. Don't do it with adrenaline. Your penis will disappear.
That's right.
I have seen it, and just like whoop, it's gone, and it's terrifying. It's okay in the end, but don't do that. Use plain xylocaine if they've got pain, and that can make it feel better. But there's a few guys like that. So sometimes I would give people a Caverjet type injection with, and I use prostaglandin, which I get as a bulk thing, and I mix it with some xylocaine, plain xylocaine.
And someone's wondering if you inject both sides?
No, because they're connected across the middle. There's multiple. If you ultrasound the penis, you'll see right down, there's 4 or 5 connections. If you go from the stomach right to the glands, across where there's little canals across, and sort of instantly, if you inject on one side and give it a bit of a squeeze around, you'll find it'll go onto both sides at once.
Great, thank you.
Now, just another thing I've sort of have been interested in recently, which is just one quick slide. Think about pornography. Sure. My psychologist friend said when mobile phones were invented, girls embraced them to text bully all their girlfriends. Boys embraced it to watch pornography. And from 12 or 13, they're watching some really heavy-duty pornography, and they're getting super stimulation type with this. Then they go and meet a partner and try and have a normal, what does that mean now? What does that mean? They don't know what that means anymore, a normal sexual interaction. and there's not enough stimulation, and their erection fades away, or they don't get an erection. So I think it's a really interesting question, and I've been asking guys recently, you know, who are young guys who haven't had their prostate out or got other sort of issues, and they're saying, oh, erections. They all have said, and this isn't a scientific study because it's just in my practice I've been asking about, but every single guy I've asked, every young guy who doesn't seem to have a problem but says, God, I'm having some difficulties with function. I said, well, how much porn do you watch? Oh, you know, just normal. Well, that's interesting. What's normal? I mean, and apparently, like, it's all the time. Getting up in the morning, going to bed, whatever, you know, short of something to do, watch some porn. And then you try and have a, whatever that means, normal sexual relationship, so there's not enough stimulation. Interesting question. So just think about that. If you get a young guy and you don't say, oh, at your age, what, you can't have a problem. Really, this guy, it's very hard for a young guy to come in and talk about his lack of sexual dysfunction. He doesn't do that lightly. Dismiss him at your peril. Okay, so what we see a lot of is this erectile dysfunction after surgery. And everyone's worried about getting prostate cancer, and everybody wants to get their prostate out so they don't die of cancer. And I have had a lot of guys say, I wish I'd never done the test because, you know, my life's not worth living now because sex used to be great. And I think the guys who really suffer are the guys who have fabulous sexual function. They just don't get it, that they've got a great gift and they've got fantastic sexual function. Oh, and people go, oh, they're just normal. No, look, there's a normal distribution curve of life, and these guys are right up one end of it, and they just, anytime there's sexual stimulation, they get a terrific erection. Whenever they need it, they can often drink a lot, it still works, they have a fantastic time. So when the doctor says in the informed consent thing, look, it might affect your sexual function, it goes straight over their head. They don't even, oh, that's not going to affect. It's like saying you won't be able to breathe in 5 minutes' time. What are you talking about? I won't have any problem. Well, these guys are devastated. It's just like pulling the TV set, unplugging the TV set. You play with the knobs all you like, nothing is going to happen. These guys are devastated. So we ought to expect that there can be problems after that. And so these guys, Viagra, and the theme of the night was what to do when Viagra doesn't work. These guys are probably not going to have great function. You can, and interesting, I show this picture to patients, okay, and they go, I say, now there's your bladder up here, and there's your prostate there, and there's your bowel. Wow, is that your prostate? And that's your bladder. Oh, that's your prostate. And that's your penis. Oh, amazing. And I said, well, hang on, you've signed informed consent. You've had all this cut out. And this seems like the first time you've ever looked at. You don't even, no idea what they were doing. I just had cancer and I just had to get rid of it. And that's so common. You say the cancer word, just get rid of it. I want to talk about, no, I want to just get rid of it. Just get rid of it. And people don't understand. And it's very hard to take this out here and not interfere with these nerves that are coming down here. Because it's not just unnerve like that sitting there that you can just put your nose, like when we used to be surgically assisting someone in the ureter. As a student, you were given that metal thing to put around the ureter so the surgeon would never cut the ureter. It's not that easy because this is a lot. It's like I suppose the skin of a mandarin full of tiny little fibers. You really can't just see them that easily. You can't just say, oh, I won't touch that there and I won't touch that there. You just have to be very careful and dissect around here very carefully and get rid of this and do as little damage as you can and control the bleeding. It's a very difficult thing to do and not disturb the nerves. So even when you're the best surgeon in the world and you don't cut the nerves, you'll still get some ooze and bleeding and whatever. And it takes a while for things to settle down. These guys aren't going to respond to Viagra. After prostate, you're going to get a lot of new EDs. I think the nerve sparing is good. Guys are trying, the surgeons are trying to do as little damage as possible. That always helps. But I think after prostate surgery, you've got to assume problems. I think sildenafil won't work in this case, but it may be helpful in recovery. So often the surgeons will say, look, take a half a tablet or even a quarter of a tablet every day. And when you try to have sex, have a full tablet. But the real treatment to get these guys going is intracavernosal injection. And if you don't do this frequently, and you're not comfortable with it, you want to refer. And you refer early. You do not wait and see. people think, oh, I'll just see how I go. The surgeon said it all went very well and we had, the nerves are all spared. Well, no, go in and have some treatment. If you're having some intracavernosal injections and you don't need them, you're going to know very quickly. And it's better to do more intervention rather than less. That was just some auto injectors for people who didn't. You can still get that injectees thing online. We used to have a whole bunch of them. We got them, the diabetics used them, and it was easy for us to get them. You can get them online though. There's a website if you just put in injectees. So if you don't like putting needles, and they're a very snappy little device that make injecting easily. So these are things that you think about when people have got ED. It's miserable. It does affect all aspects of men's lives. They think about it all day. They say, I'm horrible at work, I'm terrible to my kids, I'm difficult with my wife, I hate myself, and I wish I'd never done the PSA. And so we've got to say, look, that may be so, but what we want to be able to do is make this work. And honestly, we have some very angry people come into our office. And we have a lot of very happy people who leave because most of these guys don't know this is treatable. It's really sad to see people who have 3, 4, 5 years post prostatectomy and they didn't know and they weren't offered any treatment. And I was amazed. I had a patient who came from Hamilton and his surgeon said, well, you haven't got any sexual function? Of course you haven't. You've had prostate surgery. That's not going to happen. Off you go. And he went to another urologist in Hamilton who said the same thing. And he came to me through a doctor in Hamilton who knew me, and he was very apologetic, saying, I know this won't work, but I'm just desperate because he's 48. And he's a really young guy and a lovely guy who'd been told you can't do anything about it. He was blown out of the water when I said, look, we can give you an erection. We can make this work for you. And if there's recovery, this is going to keep your penis in good condition so that if you get recovery, which may happen 2, 3, 4 years out from the surgery. So it's a slow process, but it's a bit like having your knee operated on, have your cartilage taken out. You don't just say, well, go home with those crutches and a bandage and we'll see you in a couple of weeks. We send you to the physio, and it's really dependent on doing lots of exercise to keep that muscle going, how well you are going to do after this surgery. And after you've had prostate out, you just have to keep things going. Otherwise, your penis will disappear. Patients will always say it's getting smaller and it's losing condition. And that's not surprising because that's what happens. And so I think you want to also remember that there's no such thing as an uninvolved partner. So people say, look, I tried Viagra, it didn't work. My wife says it's terrible, I don't know, get fixed. And I think, well, that sounds like you're going to the vet. I hate that. And I'm really happy if couples come and see me together. And I think it's a great thing. So you know what's happening. But also remember, your patient, their sexual partner might not be their wife. So you need to just be aware of that. But as astute GPs, you would think about that. So you need to be cautious. And of course, yes, don't say to the wife when you see her at the next visit, how's your husband's Viagra going? Because it might not be her he's using it with. Just a tip, I've seen that mistake made. So communication is important. I quite like that slide. You're checking, aren't you? Yes, it does work. So, but I think also be aware of your personal biases with this. And I think you want to be aware that there's an extraordinary number of sexual orientations and anyone can do whatever they want with anybody as long as it's mutually consensual. I think you have to be aware about being ageist. When you're 30, you think 60 or 70 is old. When you're 60, you think 80 is old. My oldest patient has been 90. My youngest patient has been 16. I think you just have to get that out of your brain, saying, oh, at your age, or why are you looking at this? So think, well, what are you talking about? Think about your personal bias because you're thinking about yourself and you have no problem yourself. So you think everybody at 30, 40, 50, 60 should be fine because you are. Well, you're very lucky if you don't have any problems. But this is no different than high blood pressure or diabetes or any other medical condition. You just have to take it bit by bit. Be aware of of what's going on. Everybody can have anything basically. Don't try and put them in a pigeonhole. Ask what is really happening. ask them what they mean when they say this drug isn't working, because people will mean different things. And absolutely beware of unrealistic expectations. I'm constantly hear myself saying, look, I'm sorry, I can't make you 25 again. I just want to have sex all weekend like I used to. Well, I'm sorry. That's probably not going to happen. But we like to think as you get older, sex gets to be a bit more quality. And I think there's more to sex than just intercourse. And sometimes you have to talk about that. And absolutely, when Viagra came out and they said it will fix everything, and so all you guys working in this business will be out of business. Well, interesting study they did. Only 16 people, 16% of people got a repeat prescription out of a large number of people getting Viagra. Why? Because they were taking it for the wrong reasons. A lot of people did get better once they took some Viagra. They kick-started everything. And so they said, well, I don't need to take it anymore. That was great. Some people got side effects they didn't like. But it was surprising that there wasn't it's a great drug. It's a great drug, widely prescribed, but it just doesn't cure everything. And certainly, if you're having relationship issues, you should be having your psychologist on speed dial, because unfortunately, it can be expensive having psychologists, but certainly can be money well spent, because they do some great work, because a lot of us get pretty screwed up by this stuff. And so thank you.
Right, we do have some questions that have popped up through the talk, so I might just backtrack back to some of the subject headings and go through some of these questions. So we'll start with premature ejaculation, just a commentary on the SSRIs. You talked about using paroxetine as a good SSRI for premature ejaculation. Someone was asking the question, if they were to take it on a PRN basis, what time?
I think if it does work, and it's not necessarily going to work as best like that, probably 2 or 3 hours before. You want to take a decent amount of time.
Okay.
Don't. And the problem is, like Viagra, people take it and they jump into bed, and it doesn't work. Yeah. So plenty of time.
Are there any other alternatives apart from paroxetine that you would recommend? In general practice, often we find that paroxetine has quite significant withdrawal effects just because of the timing, but it's got such a short half-life.
Yeah. Look, I think all the SSRIs to a degree will slow down ejaculation. It's just paroxetine is the best drug. But I think, all of those citalopram, all those sort of drugs will to a degree stop that. Sertraline, there's a lot of those things will slow down ejaculation, but paroxetine is just the best of the bunch. Gotcha. But you can try any of them.
Okay. And someone's asked the question, the role of tramadol in premature ejaculation, and with regards to treatment, I wasn't aware that this was a form of treatment.
Yeah, I don't use it. It does actually slow things down.
Oh,
but I don't use it. Okay. I haven't had any experience with doing that. It's a sort of can make a lot of people feel pretty ordinary, tramadol, can't it? It makes red wine taste terrible, I found out when I broke my leg.
And I suppose it's got other potential issues with opioid use and things like that.
Yeah.
That perhaps would be best left alone. Now, if we track now to erectile dysfunctions, we had a few questions come in with regards to individuals that are on nitrates and GTN spray. Is there any role of sildenafil here, and if not, is there something else that can be used?
Yeah, well, it's a contraindication, isn't it, to sildenafil, and the occasional report of profound hypertension, and everyone was always scared about that. So we don't give that to people. And in the early days, someone had a GTN spray. They weren't given a repeat of their Viagra because we were scared about it. Well, you can use your Viagra if you've got the GTN spray, but you've got to realize if you get angina, you shouldn't just reach for your GTN spray, because it can be dangerous. And you've got to tell your ambulance man when they come in, because the first thing they might do is give a spray under your tongue. So you just want to talk about that.
Okay. And is there any benefit of the tadalafil versus the sildenafil with regards to data in terms of superiority in treatment, or are they just different?
Yeah, they do the same thing, and basically we say, look, try them. The only way you're going to know, because they both work well for the right people, but it's about side effect profile, and it's about people who like to, the French call it le weekender, don't they? So you take it on Friday night, you don't need to take any tablet all weekend, and you can have enhanced sexual performance. And some guys just love that. They take it on Friday night, they can drive away for the weekend, and they don't have to take any drugs that you're going to leave an embarrassing place in your friend's batch or something. And yeah, so it's absolutely personal preference. When Cialis came out, I remember I had 3 patients in a row who came and said, this is the most wonderful drug I've ever had. And I thought, gee, Pfizer are on the back foot here. But then, you know, people came in with the complaints and the back pain and the aches and pains, and it didn't really work for this guy, and someone else had really stuffy headache and a hot face and things. So look, the side effects will happen with both of these drugs. The only way you know is to trial it, and you've got to give it a bit of a trial. So if you get a terrible headache today, it doesn't necessarily mean you'll have a terrible headache next time.
And what's the cost of the medications these days in terms of per tablet? Do you know?
Oh yeah. The Viagra, because the Viagra's and the sildenafil is off patent.
That's right.
Hide that noise. And so it's quite cheap, and I think like a box of you can get it from pharmacy direct. It's $20 or something, isn't it? $30. They come in 4s and 8s and 12s. So it's actually very affordable. The Cialis is still patent protected for an indeterminate time. I can't find anyone who's going to tell me how long that's going to go on for. But basically, we get 4 and 8 tadalafil 20 milligrams in a box. 8 is $250 or $240, I think, for 8. So it's reasonably expensive. But, you know, we've got a bunch of guys who are very, well, and maybe not happy to pay it, but because it works for them, they will have it. There's a daily dosing Cialis too, which we don't have a lot of people using now, but taking a 5 milligram tablet every day. So it costs you about $200 a month to take this drug. So $2,500 a year. A lot of people are prepared to do that.
Now, moving on to the intracorporeal injections, many general practitioners and other primary healthcare providers work in smaller centres, and there are some questions coming through with regards to how they access this sort of treatment in primary care, and can we give injections like this in primary care? Any comment?
Oh, absolutely. Absolutely. That's where these injections should be given. I think this is an integral part. People say, when do you do your men's clinic practice? In my general practice, I say, well, I'm not going to make guys sit down there in embarrassment on a Tuesday afternoon and say, this is where we see men with sexual problems. We just mix it in with our general practice. It's a general practice thing. We change the times of practice. When I'm seeing a new patient, I give them a big, very long, a long visit. And I've been doing this for a long time, so I've set up so I give people 45 minutes or an hour to do this. And in between that hour, I might nip out and do something else. But basically, we have a long appointment and we have shorter appointments for other things. And we just do this as required. And we can actually inject patients. I've gone off the question a bit here, but we can inject patients in the practice, and everyone says, how can you do that? You've got children running around and everything. It's actually, you don't make a big fuss about it, and you've got sensible reception staff. It's not actually a big deal. It would be very nice if you've got a spare room that you can use for doing this. The drugs, you can get just Cavaject is just a pharmacy. It's just available. Just write a prescription. It comes from your chemist. We also use other drugs for injection. You can use papaverine, regitine, and prostaglandin. You can get all of these drugs in bulk form. If you're going to do a bit, you don't want to do. If you're not going to do a lot of it, you don't want to do it because they're expensive. The drugs are expensive, and you get them in bigger amounts, so that you've got to divide them up and then pass them on to patients. and you've got to give them a trial in the office, and you can use either prostaglandin. If I'm seeing post-prostatectomy people, you would always start them with papaverine regitine mixture. And you might have to contact me if you wanted to know the exact doses. It's a bit scary if you start putting injections into men's penises. At the first stage, you think, goodness, what's going to happen? But as long as you keep the dose low and go slow, you usually, you'll get the hang of it. And it's not actually as difficult as you might think. But yeah, you probably need, see one, do one, teach one. You need someone to show you, because it's just, how on earth do you do this? So, I'm surprised the number of patients who come back to me and say, my injection isn't working. Now they're sticking it in between the two corpora. They're sticking it on an angle into the penis, so it's not going in there. I've had 2 men saying, this is ridiculous, it's so painful. They were sticking it into the glands. I just about passed out when they described it. I thought, how on earth could they have got that wrong? But they did. And I had another man who said, I've tried several injections and nothing's happened, and he was injecting it intra-abdominally. So you have to get these guys to sit down and do it in your office. You can't. And every time people have said, no, I know all about this, and they take some away, they get into trouble. And they'll come back with a huge hematoma, and the worst thing that can happen is they're in hospital with a priapism, because they've just had no idea between seeing you and going and doing the treatment. They've completely confused it. So I give some printed material on what they're supposed to be doing.
Great. And before we finish up there, just a sort of commentary on alternative treatments. Someone's asked here, and I hope you know what this is, what are your thoughts about the pea shot? I think it's called protein-rich precipitate, and whether or not this works for people with dysfunction.
Yeah, well, it works, I think, in that it makes a lot of money for someone. I don't believe there's necessarily any science. It's offered by, shall we kindly say, alternative clinics. I certainly wouldn't send any of my patients there. I've had several patients who's been there, and there's several $1,000s for the treatment. And the patients who've come to see me, well, they're not going to come and see me if it was successful, are they? They've come to see me, have a bit of a bitch, and say, it was an awful lot of money for no result. I've always say the option is you could go to the medical council and close these people down, because I think this is cruel. If you want to make money in this life, you can sell drugs to people with cancer and everyone will try it. And you can sell money to people with sexual dysfunction and they will try it. If you get guys like I see every single day who have got sexual dysfunction and cancer, these guys are desperate. They will try everything, and it doesn't matter. Money is no object when you're really desperate, and they'll spend $5,000 or $10,000. Really, I have people who've spent $10,000 on alternative treatments, and they are scams. And we have to call them this. And you don't, these people will say, oh, it's wonderful. And the only articles I've looked for scientific journals talking about the pea shot, I have only ever found daytime TV chat shows in America with the guy who supposedly invented it promoting it. So I'm very happy if someone can show me the Journal of Urology or something with a scientific article about it. But I really, and I speak to the guys in Sydney quite frequently who run these big clinics, Chris McMahon and Mike Lowy, and I always talk to them about that stuff, and they haven't heard about it. And so I think be very suspicious. I think when it's too good to be true, it's too good to be true. There was a comment in The Guardian recently about someone had looked at all these so-called natural cures, Tribulus, Ignite, and that stuff. No one's found any evidence that this stuff works. Of course, there is a small percentage psychological advantage. If I'm taking something that's going to make me feel good, well, I'm going to probably feel good before I realize, I actually feel pretty much the same as I did. But placebo is a wonderful thing. It does make you feel a bit better. And so a lot of drugs are sold as sexual enhancement products, but actually it's placebo. And it's okay if it's not expensive, but it really is, it's criminal to sell stuff for thousands and thousands of dollars to people often who can't afford this, but who are desperate. We should be treating these men in our clinics and we should be making it easy for them to come to us and talk about this. And I had a doctor said, oh, I never see patients like this in my clinic. I don't have any, you know, I think you're just trying to sell stuff for drug companies. And I said, that's because you make it too difficult in your practice. How many diabetics, how many hypertensives, how many people drink too much, how many people have had prostate surgery? Do you offer these people help? And we don't. We're not making it easy for them. You have to make it easy for them. You have to say, this is very common and I can help you, and they will love you forever.
Fantastic. Well, thank you, Warrick, for coming in and talking to us about the medical management of erectile dysfunction.
I hope that's helpful.
It has been.
Well, actually, it wasn't about that. It was about what to do when Viagra doesn't work. But we did digress a bit, didn't we?
A copy of this video will be available on our website in due course, along with any other relevant websites. Thank you, everyone, and good night.